Welcome, everyone. Yes, we are going to be recording the meeting. Thanks, Ina. So I'm April Pettit. I am one of the PIs for the Tennessee CFIR Implementation Science Hub. My co-PI is Carolyn Audette, and she is traveling for business, so she is unable to join. But I will introduce our speakers here in a minute, but if you all want to wait until the end to ask questions, you can raise your hands at the end. But if you need to put a question in the chat so you don't forget about it till the end, feel free to do that as well. And then our speakers do have some time after this for consultations. If that's something you or your team are interested in, you can stay on at the end. So we'll kind of reassess who wants to stay on after that. So we have two speakers. They're going to be tag teaming today. So Caitlin Reardon is a qualitative methodologist. She received her MPH from the University of Michigan School of Public Health. And Andrea Nevedal is a medical anthropologist and qualitative methodologist. She received her PhD in anthropology from Wayne State University and completed a postdoc at the University of Michigan. And they were both mentored and trained by Laura Damschroeder, who is the lead developer of the Consolidated Framework for Implementation Research, or the CFIR. And they're both currently working as independent contractors in the VA health system. And they're going to be talking today about the CFIR, which was originally published in 2009, and we'll also be sharing about updates to the CFIR from 2022. So welcome. And we can see your slides, so. They were in presenter view, but now, there you go.
No, there we go. I
Yeah.
couldn't, it wouldn't bring the drop down again to let me unmute myself. So I had to drop out of presentation mode. Anyway, we made it. So thanks for that introduction and thanks so much for having us. Like April said, this talk's really going to be focused on the CFIR as well as updates, including sort of the CFIR outcomes addendum, which is sort of part of that body of work. Like April said, I'm Caitlin, and I worked with Laura to develop the updated CFIR and the CFIR outcomes addendum. And I'm currently working on a user guide that could help teams sort of use the CFIR, the updated CFIR in evaluation. And I've worked with teams both within and outside VA, and I'm a member of our sort of CFIR collaborative, which is the team that's trying to sort of steer and direct ongoing development of the framework. So, and I'll let Andrea introduce herself.
Hello, I'm Andrea Nevedal. Thanks for the introduction so far. And I've worked with Caitlin and Laura since about 2016, where I was able to learn the CFIR. And Caitlin is like the best person basically to be talking about the CFIR. So I'm excited and that she's presenting and leading this one today. And I've worked with teams within and outside of VA, and a lot of my work focuses on using qualitative methods and rapid qualitative analysis. And I'm also a member of the CFIR collaborative as well.
So we'll start off talking about CFIR generally and the updates. And I know that it sounds like this crowd is sort of mixed, so we'll start a little basic and then get into the nitty gritty. But essentially, you know, CFIR is a determinant framework. It defines constructs or determinants across 5 domains of potential influences on implementation. And like April said, the original CFIR was published in 2009. The development of that version was led by Laura Damschroeder, as well as some other implementation researchers at the VA Diabetes Query, which was out of the Ann Arbor VA. And the original CFIR was based on 19 theories, models, and frameworks, including the diffusion of innovation, the Stettler model of research utilization, but also Greenhalgh's review, which included, I believe, over 500 sources. So it was really quite consolidated at the time. And it was developed because when they were reviewing the existing theories, models, and frameworks, and I say they because this was a few years before my time at BA, they found that constructs overlapped or were missing, constructs weren't well operationalized, and then that terminology and definitions of constructs really were inconsistent and suffered from jingle jangle fallacies. So similar labels being used to describe, really different underlying concepts, and then different labels being used to describe really similar underlying concepts. And the need was just, for more clearly defined and operationalized constructs in order for them to be measurable. And so the original CFIR was published. It's been accessed over 363,000 times. It's been cited over 11,000 times in Google Scholar, and it's consistently listed in the top 10 most accessed articles in implementation science. But it needed updates, and even within our own team, we saw that, right? Implementation science has advanced a lot since 2009. And there was just updates and growth that were needed. So we conducted a literature review with a systematic search for articles published between 2009, when the original was published, through July of 2020, which was just when we were doing the work. And we included every article that had CFIR in the title or the abstract. And that pulled 376 articles, of which 59 actually included, direct feedback on CFIR. We then did a user survey with the unique corresponding authors, which you can see is less than 376. So we had definitely some folks that were very prolific with their publishing of CFIR articles, and 40% of those folks completed the survey. We then aggregated the data across both of those sources by construct, and went through that process of really synthesizing and trying to identify themes, and used a consensus approach to ultimately finalize all the updates. There's several types of updates in the updated CFIR, and I always refer folks to additional file 5 with the manuscript, because it maps the original CFIR to the updated CFIR, and for each change, it describes the change as well as the rationale based on that user feedback. So I love that file. That was like the main piece of work. And as of this month, I actually just pulled these citations for this talk. The updated CFIR has already been accessed 104,000 times, and it's only been out 2 years instead of 13. So it was super exciting to see that. And I'll turn it over to Andrea for a couple of slides. Andrea, just let me know when you're ready for the next slide.
Okay, sounds good. So today's talk is based on the updated CFIR domains and constructs, and the CFIR domains are defined here as, so the innovation is the thing being implemented, and some of the examples of the thing might be a clinical treatment, an educational program, or a city service. The outer setting is a setting in which the inner setting exists, and some examples of the outer setting might be a hospital system, a school district, or a state. The inner setting is a setting in which the innovation is being implemented. So a hospital, a school, a city. The individual's roles and characteristics, what this means is that the roles and characteristics of individuals involved with implementing, delivering, and or receiving the innovation. Then there's the implementation process, which is all the activities and strategies used to implement the innovation. Next slide. So this diagram illustrates how the domains are related to each other. The innovation is implemented by the individuals in the inner setting, which is in the outer setting, and the implementation process works around all of the other domains. This is also the order in which we'll talk about the domains in this talk today. Slide.
So one of the big changes you'll notice when using the CFIR now is that there is a lot more additional guidance. So first, we guide users to really think through and identify the individuals that have influence or power over implementation to collect data from. And we did this because we realized that folks were actually unclear about the purpose and scope of CFIR. So We had over 20 users recommend adding a domain or constructs to capture patient level innovation determinants and wanted to use CFIR to collect data directly from recipients or patients. But CFIR is not most often not the appropriate framework to use for that purpose. Although we see hospital systems doing a much better job, increasing, prioritizing patient-centered care and having patient advisory boards and things like that, we haven't really seen that like true shared power in terms of decision-making between recipients or patients and key decision makers, in the sense of like patients really choosing what is being offered or implemented in the healthcare system, for example. So as a result, direct data collection from recipients usually informs, innovation outcomes versus implementation outcomes. And instead, data collection from, key decision makers or the folks that are actually implementing or delivering the innovation about their perceptions of recipients, true or not, which is where it gets tricky, and how those perceptions encourage or discourage, actually completing implementation is really what informs implementation outcomes. We've had folks be like pretty upset with that. And we reiterate that upset essentially, because recipients should have greater influence and authority and power in healthcare systems. But when they don't, when they're sort of not included in that, it's hard for them to speak to kind of what's going on in the inner setting in terms of implementing and delivering whatever the innovation may be. So that was one of the first pieces of guidance that we included. It's also part of the rationale for the companion paper, the outcomes addendum, which we'll talk about in the second half of this. Second, we clarify that constructs are likely to pull, a blend of objective reality and subjective perceptions based on experiences in the inner setting. Because we had folks that were they were unclear, like, am I intended to capture the actual features of the program here, for example, with the innovation domain? Or am I supposed to capture what people think? They both seem important, but this is confusing. And again, we sort of second that it's confusing, but that really both are so important. The perceptions of folks, again, whether or not they're actually reflective of reality, really they're generative, right? They drive what happens with implementation, for better or worse. And so we just highlight that, both of those might be captured when collecting data with CFIR. And third, we really, really encourage users to operationalize CFIR. So for the most part, CFIR has been used in healthcare settings, but we've also seen it used in community settings, educational settings. The one that was like the most far out for me that I loved was seeing it used in an agricultural farming setting. And so folks really wanted the language and sort of like CFIR to expand to be more applicable beyond just healthcare. But it was hard to broaden CFIR without making the language just completely abstract and strange, right? And so, we really do encourage folks to like operationalize the framework, think through, okay, yes, CFIR is saying recipient. Who are my recipients? Are they patients, right? Are they students? Who are they? And to add constructs as needed. I think that's the absolute biggest thing, is to recognize that CFIR is not a static, set framework. Users are intended to sort of make it work for their project, to add constructs as needed. And so you'll see that throughout, there's updated construct names and definitions, recipient instead of patient, deliverer instead of, maybe provider, things like that. So some of that language is, I'll be honest, a bit wonky, but was necessary to broaden applicability. So the first domain we're going to talk about is the innovation domain. There were minor changes to this domain. It's relatively untouched. And these constructs capture characteristics of the innovation itself. And we really got clear about that because users questioned, is CFIR intended to be used to evaluate the innovation or the strategy that's being used to implement the innovation? And they found it really hard to distinguish between the two of them. And, the literature has recognized that this lack of a clean boundary between the innovation and the strategy being used to implement it is a big contributor to implementation complexity. But that we still really need to distinguish them because if we don't, we can't really make accurate attribution to implementation outcomes or identify appropriate areas for future intervention, right? So for example, if implementation fails, did it fail because there's a problem with the innovation or because there was a problem with the strategy that was being used? So we really just encourage folks to think through, the innovation versus the strategy, and to use a reporting guideline to really get concrete about the innovation. What is the purpose? What's the intended impact of the innovation, and how will it be measured for, not only innovation recipients, right, but also innovation deliverers, for key decision makers? What's the type? What's the innovation type? So is it a digital therapeutic, a prevention program, a policy change, right? And then last, what are the components of the innovation, especially what are the core versus adaptable components? When looking at the constructs for this first domain, we'll only highlight, just due to time, we obviously can't talk about every construct. So as we go, I'll sort of talk about overall updates made, and then I'll highlight my favorite or like problem child construct, and then Andrea will do the same. But to start off with this domain, the big overall change was the addition of the word innovation to every construct name. And that was just to really help orient users to the focus of the domain. So again, the innovation itself, independent of the implementation strategy, but also sort of independent of its interface with the inner setting. So we actually had lots of users want to or suggest that compatibility be moved to this domain. And ultimately, we did not move it because with compatibility, you're seeing the interface of the innovation with characteristics of the inner setting. So the construct I will highlight, and this has truly been the problem child construct for me, is complexity. The definition of complexity was updated to clarify that, this is complexity of the innovation itself, not the complexity of implementation. Whereas, and lots of folks actually said, well, you need to add complexity of implementation to the framework. And we felt we couldn't do that, right? Because complexity of implementation is a function of all of the other constructs, in a way it's an outcome. So this is a construct that can be hard to ask about like the complication of the complexity of the actual innovation, but is one that we've really tried to clarify the meaning of this construct. And then I'll turn it over to Andrea for her favorite or most hated construct.
I would think relative advantage is probably one of my more favorite of the constructs. And so relative advantage is what it means is that the innovation is better than available innovation or current practice. What we want to highlight there is that it's defined in this way as a relative advantage of the innovation, but it also includes disadvantages of the innovation over others or current practice. So, and one thing we wanted to point out with this example is that all the constructs may manifest positively or negatively, which is why the degree to which was added to each of the construct definitions. So they may be defined in a more positive way, but when you're operationalizing this, you can think about it in sort of like in a negative way or on a continuum.
Yeah, 100%. That was such a huge question that folks always had. It was like, where do I code disadvantages? So I'll be honest, that's one of my favorite constructs too. It's usually not problematic, but so the next domain is the individuals domain, and this domain has been totally changed. It's unrecognizable. We ultimately created 2 subdomains under individuals because there was a lot of confusion about how to use the constructs in the original characteristics of individuals domain. Folks did not know, like, who are the individuals? Who is this referring to? And there was the sentiment that, CFIR needs to focus more on who the individuals are and their underlying characteristics. And so you'll see with these 2 subdomains, we'll get into them in the nitty gritty, but that, it's roles and characteristics, with those characteristics being largely based on the COM-B system. So in terms of the role subdomain, in the original CFIR, people were scattered across every domain. Patients were in the outer setting, leadership was in the inner setting, and then implementation roles were under engaging as a process, actually. And it was not intuitive to users. And so with this, all of the people are in one place. And again, you can see these more generic terms being used, like innovation deliverers and innovation recipients. I'll note that with the sort of consolidating all of the roles that we ask folks when they're actually doing their analysis to just note if the role is internal or external to the inner setting. And then we note that the roles are not mutually exclusive. So for example, an implementation lead may also be a mid-level leader. An opinion leader may also be an implementation facilitator, right? Depending on how people are showing up, they might be wearing more than one hat, which we see all the time, right? And especially under resource settings, folks have many, many hats often. The construct I'll highlight is implementation leads, and this actually combines two previous constructs. The original CFIR had a construct called the formally appointed internal implementation leader, which abbreviated to FAIL, which I didn't love, and then also the champion construct. And so now this sort of consolidates both to just get at folks that are leading, championing, et cetera, the implementation process. And then I'll turn it over to Andrea.
Thanks, Caitlin. So the construct that I'll highlight is innovation recipients, which is individuals who are directly or indirectly receiving the innovation. What we want to point out here is that the innovation recipients will depend on the type of innovation. So sometimes an innovation recipient might be patients if it's a patient-facing innovation. Sometimes it might be staff if it's a staff-facing innovation. We have a lot of these types of things in the VA. So depending on like what system you're working in, there may be a variety of different types of innovations that you're implementing. So, and then, yeah, one thing to think about is in a healthcare context, there may also be indirect recipients, which may consist of caregivers or patient and family members, which currently, I'm doing some work with that as well, where we're interviewing and including caregivers.
Yeah, I love you pointed that out because it's the same with deliverers. You might have folks that are directly, providing for example, if it's a program, but then you have indirect deliverers who are maybe responsible for making the referral or doing the scheduling, right? So it's like a role directly related to delivering or making sure that the innovation happens. And I think that can be tricky with when figuring out where those other people go, basically. So the second subdomain is the characteristics constructs. And what we found with the original CFIR is that the existing constructs overlap with constructs in other domains. So for example, the original construct knowledge and beliefs about the intervention essentially overlapped actually with the entire innovation domain, while also failing to capture these like more relevant characteristics. And so when we went through trying to think about characteristics, it was actually really challenging because, the characteristics that are going to be relevant for understanding implementation for the implementation leader could be very different than the relevant constructs or characteristics for a deliverer, and definitely different than, characteristics for a patient. So we didn't know how to, wrestled a lot and ultimately settled and found, the COM-B system to really be brilliant for this because it provides these broad buckets for understanding behavior change that can be operationalized to be understood for these really diverse roles, while also there's been so much incredible work done linking, for example, the COM-B to the theoretical domains framework. So it's sort of this like portal into, perhaps more like directly detailed or relevant constructs. And so with that being said, yeah, the constructs are really broad. And we just strongly encourage folks to operationalize them. And that might mean scrapping them, right? And really like looking for, maybe leadership theory provides characteristics, constructs that are more relevant for the implementation lead, right? Maybe behavior change theories give better characteristics, constructs for patients. And so really just getting concrete with your project and either mapping them to the COM-B, adding sub-constructs, et cetera. The construct I'll highlight here is the need construct. I think some folks questioned, well, if you've got motivation, right, why do you need need? Need sort of drives motivation. But we really felt it needed to be separate for a couple of reasons. The first being that, the original CFIR really just thought about the needs of patients, which should absolutely, drive decisions about adoption. But it didn't take into account the sort of needs of other folks, of the deliverers, of the key decision makers. And when, if we're thinking about not just implementation, but sustainment, we really want to be implementing innovations that, meet the needs of all of the, key participants, or, at worst are sort of neutral, right? And I think where we see this, or where it's really clear, is in healthcare systems where, you're trying to implement something and you're adding another thing to like an incredibly overburdened primary care provider, right? And it just ultimately is not sustainable for that. So that's why we kept need out, and so that it could be sort of applied across all the roles. And then I'll turn it to Andrea to highlight another construct.
Okay, I'll highlight opportunity. So opportunity is the individual or individual have the availability, scope, and power to fulfill the role. The opportunity construct was included to capture characteristics that are conferred to individuals by the broader organization or system. So what this means is this could mean the time and authority granted to the implementation lead to fulfill their role.
Yeah, thank you. That's such a tricky one too, I think, because it starts to merge into the rest of the inner setting a bit, but helps really get at those, like, yeah, if they've got time to actually do the thing that we want them to do. And then this is just a quick example of how to conceptualize this domain, especially if you're thinking about coding. We really recommend, at least with our sort of a collective worldview in CFIR land, of coding the role first. So sort of any data, any responses that are relevant to a specific role. In this case, I'm highlighting high-level leaders, to just code it to that role. And once, the data is coded, to sort of review that for the full story, the full narrative of the, the role that person is playing, and sort of pull out and then, code within that data the characteristics that appear to be relevant. So next is the inner setting, moderate changes for this domain. And with this, we really tried to provide some additional guidance about thinking about, what's the inner setting versus the outer setting. And actually, it's funny because right before this call, Andrea and I were just talking about this. Because we had folks that it was the whole gamut. It was, well, you should just combine inner and outer setting because it's all just context. And then we had people say, well, no, you should actually have multiple levels in the inner setting, like team, clinic, facility, and multiple levels in the outer setting. And ultimately, we did not do either. We just kept it right in the middle. Because again, it's important for distinguishing or for making accurate attribution to implementation outcomes. And we just asked folks to get concrete, to think about where the boundary is between the inner and outer setting, and to define if there's multiple inner settings or multiple outer settings. So the first half of the inner setting are constructs that are persistent general characteristics of the setting, regardless of what's going on with implementation or delivery of the innovation. And I'll just note that they're not included for space, but structural characteristics and culture both now have subconstructs, which were added because they were just incredibly large constructs to try to code in initially. So under culture, for example, there are two constructs that Andrea and I are going to highlight. And I'll highlight the first, which is called recipient-centeredness culture. This construct was previously part of the patient needs and resources construct in the original CFIR, which got at both, what are the perceptions of the needs that exist, as well as how much does the inner setting care about it, right? Care about those needs. And so this, that was double-barreled, obviously. And so this really just focuses on, the extent to which the inner setting is really, patient-centered, right? Or recipient-centered. And then I'll turn it to Andrea.
Okay, I'll focus on deliver-centeredness culture. So deliver-centeredness captures the importance of recognizing and addressing the needs of deliverers. And it aligns with the evolution of the triple aim, which included enhancing patient experience, improving population health, and reducing costs, and evolved into the quadruple aim, which also aims to improve the work life and well-being of clinicians and staff.
Yeah, I think we are seeing that even, especially coming through COVID, which was such a challenging time for so many providers of, if we don't take care of staff and providers, like they can't take care of patients, right?
Yep.
The second part of the inner setting, these constructs are specific to implementation or delivery of the innovation. And there are subconstructs, again, that are not included just for space. For example, under available resources, it now gets into, funding, space, or materials and sorry, materials and equipment. And the construct I'll highlight here is compatibility. This construct used to include sort of fit with work processes and fit with values in the inner setting, and it was really hard to code. We often ended up separating it into two constructs. And so as part of the updated CFIR, it now only includes work processes, and sort of alignment with values and goals is now under mission alignment, which is a different construct. And then I'll turn it to Andrea.
Okay, I'll highlight penchant for change, which has always been one of my favorite CFIR constructs. So what this means is that the current situation is intolerable and needs to change. So one example of this in some of the work that Caitlin and I do in the VA is in a current project is we see tension for change a lot in the VA for new treatments and care addressing moral injury of veterans because existing PTSD care does not address moral injury. So there was a really strong tension for change in the VA to provide care out that beyond PTSD for veterans.
Okay, so now we're into the outer setting. And again, major changes to this domain. These constructs in this domain capture characteristics of the outer setting. And similar to the inner setting, there's that guidance to really document, the outer setting as well as the boundary between the inner setting and the outer setting. In terms of constructs in this domain, I'll say this domain was really underdeveloped, and it does a better job now, I think, really highlighting how both support and pressure, may be present in the outer setting and influencing what's going on in the inner setting. There are subconstructs not listed on the slide for external pressure, and those include societal pressure, market pressure, and performance and measurement pressure. The latter being the biggest one I know that we see probably in VA. And I'll just note that market pressure was actually replaced the peer pressure construct, which was in the original CFIR. And it ended up expanding because there's really, there are many types of pressure that can come, externally into the healthcare system. The constructs I'll highlight are the local attitudes and local conditions constructs. So we had actually a pretty limited rationale for adding these. We had some innovations that required essentially participation or support from the outer setting in order to be implemented. So an example is a community housing fair, which required that, in order to be successful, they needed landlords to show up. They needed employers to show up. They needed utility companies to show up. And, at that point, then, you need to know, are the values and are the conditions of the community, right? Are they supportive or not of implementation? And in that case, unfortunately, they really weren't, because there were really harmful beliefs held about the worthiness of these veterans that were seeking housing. So we added those with a kind of limited mindset of like, these are for, when the innovation really requires support from the outer setting, which isn't always the case. And so I'm personally looking forward to just seeing how people sort of operationalize them in their projects. And then I'll turn it to Andrea.
I'll highlight another one of my favorite constructs, which is critical incidents. So we found that we needed this construct early on when we were doing this work before it was formally added to the CFIR because of the COVID-19 pandemic, and because the CFIR didn't really have any constructs to cover the disruption from the pandemic. And we noticed that a lot of the disruption from the pandemic were impacting like how we wanted to be able to analyze the data that we're using during that time period. So we saw that COVID-19 hindered implementation and delivery of in-person innovations in VA. And we also noticed that it facilitated implementation and delivery of virtual innovations. So this might be something that it might resonate with your experiences depending on the type of environment that you're working in. And other users provided feedback that CFIR is needed to add a construct to cover unanticipated events or chaos that might occur during implementation. So that's definitely one of my favorite new constructs.
Yeah, I love it. I mean, because there is just so much that can happen. I was just talking with some teams in Canada, and they mentioned that there's this essentially reorganization of healthcare system going on, and that people might not show up for the talk because like, they were like, oh my God, like what's happening? And it was just like, oh yeah, that's critical incident. Like you can't anticipate these things happening, but they end up having a huge influence. The last domain is the implementation process. And again, there were major changes to this domain. The constructs in this domain capture characteristics of the activities and strategies used to implement the innovation. And we tried to provide sort of more clarity around this domain because folks would question, why, if the CFIR is focused on determinants, right? Like, why is this included? Like, these are processes, these are strategies. And I'm personally like a big believer in the, culture eats strategy for breakfast, but we also know that the use and the quality of strategies are determinants to implementation success. And so this domain, continues to be important. But we note that CFIR is not prescriptive. One could use this domain and the constructs in this domain to sort of roughly plan out implementation. But the idea, it's sort of like overall purpose in the framework is to be looking at these as determinants to success. And then I'll just note that the CFIR's process domain has always, roughly mapped to this idea of doing PDSA cycles, and that continues to be true with the updates. So with these constructs, there's several new constructs, mostly because users referred a lot to the expert recommendations for implementing change strategies. Really just noting that, there was a really limited number of processes in the domain initially, and that there's been just so many significant advances in the area of strategy since 2009. So we added several new constructs. And I'll just note there are sub-constructs not listed for assessing needs and engaging. Those both include sub-constructs for deliverers and recipients. And then there's also sub-constructs for reflecting and evaluating that include both reflecting and evaluating on the implementation process and implementation success, as well as the innovation, sort of the effectiveness of the innovation. And then the construct that I'll highlight is the assessing context construct, which is for me fun because, when we think about successful implementation, we're hoping that folks are going ahead and assessing context to guide implementation. And so it's where CFIR starts to contain itself, essentially, as an evaluator, you may see implementers using the CFIR to assess context while you're using the CFIR to assess their determinants to their success. So it's just kind of a fun and also confusing construct at times. And then I'll turn it to Andrea.
Thanks. So I'll focus on assessing needs, which is the extent to which implementers assess the needs of both recipients and deliverers to make adaptations to the innovation or inner setting is an important determinant to implementation success, as well as equity in implementation. So while the CFIR can be used to assess context, the construct that Caitlin just discussed, we recommend using a recipient and or an individual level framework to conduct needs assessments of people.
So just overall points about the updated CFIR, we really worked to sort of clarify scope and purpose. We used, more broad and more consistent language. We worked to address gaps by adding constructs. We work to amplify, the importance of engaging deliverers and recipients, both, not only in the innovation, but in the actual implementation team. And we really encourage users to operationalize the framework by adding constructs. So next we'll turn to the outcomes addendum review, which for me is really cannot be separated really from the updated CFIR. It really, to me, feels like the sort of same body of work in the data and the same data sources as well. In fact, it was published first before the updated CFIR. So why did we do this, right? We had a lot of recommendations to add outcomes, both implementation outcomes and innovation outcomes to CFIR. And we had some users and authors address that gap by linking CFIR with another framework. So 19 had used CFIR with REAIM, and actually our team was one of those. And 8 had used CFIR with the implementation outcomes framework. And actually our team was, I think, one of those as well. And to be honest, we were really torn about this. CFIR is a determinant framework. It's not an outcomes framework. But, you know, we always are encouraging folks, and implementation science has so gone in the direction of, you know, like make sure that you're linking your determinants to relevant implementation outcomes. And so, you know, ultimately we decided as an addendum, right? Because it was this opportunity to clarify, you know, what CFIR is and what CFIR is not. And really, like, I'll be honest, for maybe selfish reasons, this sort of practical utility for coding purposes. You know, so often when you're collecting data, folks, especially sort of post-implementation, folks are talking about outcomes. You know, they're talking about how well implementation went. They might be talking about patient outcomes from programs. And we never had a good place to put that information, even though we definitely wanted to capture it. And I've seen teams sort of force it, like, you know, like a statement like, yeah, it's working really well for our patients. And they'll code it to like innovation evidence base, right? As a form of like provider viewed evidence. And, you know, at that point, it wasn't a determinant, it was an outcome, right? And so this helped sort of just think through, right? Determinants versus outcomes and where to put that data, where to code that data. But the goal was never to create, you know, a whole other outcomes framework. And the outcomes in the addendum, they're both mapped to REAIM as well as Proctor's implementation outcomes framework in the paper. But our goal was really to think through sort of anticipated versus actual implementation outcomes, implementation versus innovation outcomes, and then also these CFIR-based implementation determinants versus innovation determinants. And so the addendum, like I said, actually came out, I don't even know, several months before the updated paper, updated CFIR paper, and it's been accessed 43,000 times. So that's my little plug to read the addendum as well. So we'll start with talking about implementation outcomes. So these are conceptualized as, you know, broadly success or failure of implementation. And these are based on the REAIM framework as well as our own work. And where we separated out was really thinking about anticipated implementation outcomes. And these really represent the likelihood of future implementation success or failure. And so they're prospective. These outcomes are forward-looking, where, you know, constellations of CFIR determinants would predict these outcomes. And then for actual implementation outcomes, those are conceptualized as current or past implementation success or failure, and where they're assessed retrospectively, right? These outcomes are backward-looking, and those constellations of CFIR determinants explain those outcomes. And we really focused on these three big, you know, adoption, implementation, sustainment, feeling that, you know, these are really the ultimate goals of implementation efforts. You know, the decision is made or not to deliver, right? Or to implement is adoption. Whether or not that delivery actually occurs, implementation, and whether that delivery occurs over the long term as sustainment. But, you know, as we were doing this work, you know, the implementation outcomes framework lists acceptability, appropriateness, and feasibility as implementation outcomes. And in the original CFIR, the implementation climate and implementation readiness were two constructs initially in the inner setting. And, you know, it's a little bit challenging to figure out what to do with these, because they're not implementation outcomes in the sense of like whether or not implementation was successful or not, but they're not just basic sort of determinants, right? They are also constellations of CFIR constructs. And so we stumbled on a paper by Catherine Riley called Comparing, Contrasting, and Integrating Dissemination and Implementation Outcomes included in the REAIM and Implementation Outcomes frameworks, where she referred to the outcomes from Proctor as antecedent assessments. We just felt that was perfect. And so are sort of carrying her work forward as well. And then obviously including the implementation climate and readiness there as well. Next, I'll talk about innovation outcomes. These are focused on success or failure of the innovation, you know, based on the impact of the innovation on three, you know, important constituents: the recipients, the delivers, and the key decision makers. So, you know, in the same way I said earlier, the updated CFIR includes need for each role. You know, it's important for those innovation outcomes to take into account, you know, all the interested parties as well. And when we do, hopefully we see, you know, more sustainable innovations, but also more equity in implementation. And then the last part of the outcomes addendum really just looks at determinants. So where CFIR implementation determinants are influencing the antecedent assessments and implementation outcomes, innovation determinants are influencing innovation outcomes. And when we think about innovation determinants, we're thinking about sort of actual recipient characteristics, demographics, recipients' sort of preferences and needs, things like that. And so where CFIR really shines, right, is these determinants to the, the first half of the outcomes addendum or framework of thinking about determinants to, implementation itself. And then just quickly thinking about sort of CFIR applications, and then we'll have lots of, we can stay after if there's questions, but really thinking through, what can you do with CFIR? And, mostly folks are doing implementation evaluation design. So assessing CFIR constructs, barriers and facilitators to predict or explain implementation outcomes. The secondary use, and I kind of alluded to this, is that, you could use the CFIR process domain if you wanted to guide implementation sort of roughly, and you could obviously use the CFIR to assess context, which is a construct in that domain. And then I'll turn it to Andrea.
Sure. And so I just wanted to point out that our next presentation will highlight some of the ways that we use CFIR in our evaluations. And so we'll highlight 2 different methods. So we'll highlight just briefly the traditional in-depth qualitative approach that we use, and then a rapid qualitative methods approach that we developed over time to help us to be able to more rapidly do the work that we do and disseminate information to our partners and in publication.
And so in terms of future work, I did mention this user guide that's in process, and that will include updated questions based on CFIR for interviews and surveys and coding guidelines. And actually there's a draft of that already. So if folks want it, I'm happy to share as long as folks keep it within their team. We are working on validating a CFIR survey against, using the full interview process for construct validity. And then they're also working on an updated CFIR ERIC mapping. So that's everything. Please reach out if you have questions. We love getting questions. And I actually just realized this is not updated. I apologize. I'll put Andrea's email in here. But yeah, and then we're also ready for questions now.
Awesome. Thank you. If anyone has questions, if you can drop them in the chat, or feel free to unmute yourself or raise your hand. I just, one comment, I appreciated your discussion around the individuals, because I feel like that's a common pitfall we see, is people wanting to use CFIR for recipients of interventions. So I just appreciate and the guidance around coding by role, I think is also useful.
Yeah, definitely. I mean, it's not just, even like grant reviewers will really push people to use CFIR to interview patients and to collect data from patients. So it's just interesting because there's frameworks that are designed to be used with patients, right? That aren't like at the intersetting, like collective level. So to me, it seems like a strange, it can be adapted, but it seems like a strange adaptation when there's existing frameworks out there.
We've often been using like the acceptability framework for patients or providers. I think sometimes people want to use the CFIR because I think they think it's easier to just use one framework for everyone. And so then it gets a little bit tricky when you start to have to add in all these different frameworks and whatnot.
The other thing that I've personally struggled with a little bit is projects that have spanned since the CFIR was updated. And we've even had like we have a paper under review where they asked us about this, and I was like, well, my argument is like, when we designed the project, we chose domains and constructs that we were gonna focus on, and we can try to force some of it into the new, but yeah, that's just something I really like the updated CFIR. But yeah, this won't always be an issue, obviously, but with COVID, some projects got delayed quite a bit. So
Yeah, no, definitely. And I'll say, especially because there is a mapping. I was going to try to pull up that additional file 5 quick. But it isn't a perfect mapping, right? Especially because, some constructs like are split in two, right? So something like networks and communications, if you had coded there, is now split into two. And so it would be, it's possible, I think, to look at it, to look at themes. You would never want to recode, but yeah, that mapping is there. I was just gonna pull it up really quick. I'm not being the quickest, but
no, I think I might have missed that when you were talking.
and there's actually another version of this file that's just just the mapping without the rationale. So we did a couple of versions of this. Can you see the document?
Mm-hmm.
Okay. So it's a little bit neater. It doesn't have all the rationale, but it still has the construct to construct map. It just has these gray rows of construct to construct. So anyway, that's there for help. But yeah, I encourage just be publishing under with the original.
Any other questions? And our speakers do have, we had, I think, asked people if they were interested in consultations where you could maybe ask questions specific to a project you were working on. But so if you have those, feel free to stay on. And there's some time for that. But just want to say thank you again.
Thank you. And if anyone has a question, we also could build in a couple minutes in the next presentation too. If people, have any questions that they think about, they could type it in the chat or let you know, and then we could always try to quickly address that in the beginning of the next one if it's helpful.
Okay, cool. Paul, I see a hand.
Yes, thank you. And thanks for the presentation. I'm coming from the University of California, San Francisco, and for part of my project, we're proposing to use the intersectionality enhanced CFIR, and I was curious if either of the presenters had any thoughts about that and how it integrates into the main CFIR. I'm still learning more about it, but even from what I have gathered from it, it seems more identity based in terms of the adaptation of the questions as opposed to structurally based, which is more in line with intersectionality theory. So I was just curious about your thoughts.